I would like to invite my panel up here because I don't intend to do much. We have Dr. Joanna Vergidis, already known to you. Joanna is a medical oncologist who treats mostly GU cancers in Victoria at the BC Cancer Center there. We have Dr. Krista Noonan. She's also from BC, works at the Fraser Valley Cancer Center in genitourinary cancers. And for gender equality, we have Dr. Peter Black. Peter is a urologic oncologist at Vancouver General Hospital in UBC, and one of our closest collaborators on the surgical side. And we're going to start with Peter. Peter has a small presentation about a very important question, or two very important questions for kidney cancer patient. One is the question, when and when not should we take the kidney out if the cancer has already metastasized? That's a concept which we call cytoreductive nephrectomy and has been around for many, many years as a milestone in the treatment of kidney cancer patients. And there were recently some developments which I think are important to discuss. And then Peter will also briefly address the questions and realities around how should we follow kidney cancer patients where the tumor has been successfully removed and there are no metastases. Does that work? Yes. Okay. As you wish.
Might as well. Okay, welcome everybody. I will fly through this relatively superficially. So the first question was actually around follow-up after nephrectomy. So if a patient has a tumor that's localized to the kidney and we're doing either a partial nephrectomy or a radical nephrectomy, do you need follow-up? And if you're going to have follow-up, how are we going to do that? So the question is, why would we do surveillance? And this is a bigger question for any cancer. Should we do surveillance and why should we do it? Of course, the big reason is to identify recurrence that can be treated and can be treated either with curative intent or in order to prevent complications that otherwise would happen if the recurrence were left unchecked. Follow-up, of course, you can see it as more than just cancer follow-up. For example, you want to monitor kidney function and make sure that the kidneys stay healthy, or if it's only one kidney remaining, that one kidney stays healthy. So there's certainly things to follow for. I put up there the third point, patient reassurance, and I would say that, of course, this is important, but sometimes there's too much follow-up done because patients are asking for too many tests because they want more reassurance than we actually should be providing with potentially invasive tests. So that's a double-edged sword, how much we do for reassurance. So especially in kidney cancer, we have very good reason to do follow-up because we know that we can treat recurrences if they're limited. There are other cancers where you might say there's less that we can do about it. So what are the harms for follow-up? Why would we potentially not do follow-up? And this is, we follow up everybody, so it's not so much why not to do it, but why do we try and do it rationally and actually limit the number of tests that we're doing. So one thing is the potential dose of radiation that accumulates over time from all the scans that we might do. So if we're doing a partial nephrectomy for a small renal mass, and the risk of recurrence is extremely small, it just does not make sense to do a CT scan once a year for 10 years. That's a lot of unnecessary radiation. So we have to balance the pros and cons. There's potential for kidney damage and also allergy from IV contrast that we might be giving with either CT or MRI. Another thing to consider are the false positive findings. So if I'm doing a scan to look at the kidney and we find something sort of accidentally or incidentally in an adrenal gland, for example, well, now we have to work that up and figure out what's going on with that. And for the most part, it's a bit of a red herring, and you can invest a lot of energy and cost. The other thing I think to think about in our world of limited resources is if we're doing a lot of unnecessary scans, for one thing, we're making access difficult to those scans for somebody who actually really needs it. And I'm sure a lot of people in the room have waited longer than they would have liked to for a scan when it was really necessary. So too much follow-up can be harmful, and we have to find the happy medium. The fundamental limitation on saying what is the right follow-up is that we don't really know. There's no evidence that tells us when to do what tests, and if more tests is going to save more lives or reduce side effects. We don't know exactly what to do. But using some kind of expert consensus is better than leaving it up to the willy-nilliness of the individual physician, whether it's a radiologist, a urologist, radiation oncologist, or medical oncologist. So the idea with guidelines is that we can avoid over or underutilization of tests. And this is just an example. This is a Canadian guidelines for follow-up after nephrectomy. So this is the type of thing that hopefully your urologist would have on the computer or somewhere printed out in the office and would be checking. You come in, so you've had a small renal mass removed by partial nephrectomy, let's say, and it's confined to the kidney, so it's a pathologic T1, and you would go across the, do I have a pointer on here? I think so. No, that's not the pointer. There we are. Is this a pointer? No. Anyway, you can go across, is it supposed to be a pointer on here?
That's supposed to be a pointer.
Okay. Yeah, it is, sorry. So you can see, so the most important one, or the one we think about the most, is imaging of the abdomen, so a CT or an ultrasound. And you can see the Canadian guidelines are saying after a partial nephrectomy for a small renal mass that you only get imaging at year 2 and year 5, and that is it. And I actually find it very hard in routine practice to tell a patient, let's say I see the patient 3 months after surgery, make sure everything's okay, and I say I'm not going to do any imaging until year 2. The patients generally don't like that, and it's hard to rationalize. There are other things, this is history and physical exam, blood, chest x-ray. Anyway, we do have sort of consensus guidelines that we try to stick to so that we're not doing too much or too little. That's all I was going to say about follow-up. Did you?
Any questions about this? Yes.
What are the dangers of from radiation from CT scans? I mean, probably most of us here get 4 times a year.
Yeah, so it depends, right? So there are a lot of patients with localized kidney cancer who definitely don't get it 4 times a year, but if it's a more significant cancer, then it's necessary. So I don't want to scare anybody who needs the scans, but the number of scans has to meet the risk of the disease. So the biggest concern around too many scans is a longer term risk of second cancers from radiation. So Christian and I share a lot of patients with testis cancer. Testis cancer is a disease of young men in their late teens to 30s, and it's almost always cured. And then if you're doing too many scans in your 20s and 30s, and you're going to live another 40, 50, whatever number of years, then that radiation dose is clearly important. So it all depends on disease context, but.
Yeah, theoretically, any radiation dose you get can theoretically increase your risk to develop cancers down the road. Now, when we say cancers down the road, radiation-induced secondary cancers usually happens 15, 20, 25, 30 years later. So at the end of the day, every CT scan is what I would call a risk-benefit analysis. Do I have enough reason to do the scan, and do I get information out of it which supersedes the risk that something happens? And you have to take into account the circumstances of the patient. In a 25-year-old, I would be a lot more restrictive with my CT scans than in a 70-year-old. So that's what that means. And that's what we do in clinical practice. We really think about every CT scan we need to do. What information do we need, and can the CT scan give us that information? And is the information worth enough a CT scan? Any other question? Post-lunch tiredness. Good. Okay, then why don't you continue, Peter, and then we get to the next part.
So this next question is for patients with metastatic kidney cancer, with the kidney still in place. So usually it's initial diagnosis of kidney cancer with metastases. Do we do surgery first to remove the kidney, or do we send the patient off to one of these three fine medical oncologists here to do systemic therapy? So to give drugs, whether it's, it used to be immunotherapy, so the old immunotherapy, and then it was drugs like sunitinib and pazopanib, and now it's the new immunotherapies again. So which should come first, systemic therapy or surgery? So back in the 80s and 90s, it would have, so as a urologist, if you're doing your licensing exam and you said you were going to do surgery on a patient with metastatic kidney cancer, you would have failed the exam and gone home. Because in general, you didn't do surgery on anything metastatic because it was considered futile. But then there were trials. There's one big trial, for example, this one published in New England Journal in 2001, that showed that cytoreductive nephrectomy, so removing the kidney in the context of metastatic disease, was beneficial for survival. And this was in an era of immunotherapy with interleukin-2 and interferon, which is fairly ineffective. But in that context, surgery was clearly beneficial. And that era evolved into the targeted therapy era. Let me just go back for a minute, with especially sunitinib and all the other drugs that have followed along. And for years we've debated, well, should we still be removing the kidney or not, now that we have more effective systemic therapies? And I think there have been different spins on the story depending on where you are. Certainly in BC, we've supported the idea of still doing nephrectomy, and all the trials were done and patients had nephrectomy. But it really went unanswered for a long time. And then last year, we had two trials that were published. One was a small trial that doesn't tell us very much, but one was a big French trial called Carmina. And the headlines from this trial were that we're no longer supposed to do nephrectomy for patients with metastatic disease. It does not help. Stop doing it. It was all over Twitter. Medical oncologists were certainly telling urologists, no more nephrectomies. And the question is, where has the dust settled? And I'll come back to that. And of course, now in 2019, it's not even the targeted therapy anymore. We're now back to immunotherapy, but much more effective immunotherapies. So the treatments that we're going to give these patients with metastatic disease, when we're thinking about nephrectomy or not, are very different again. So now the question is Carmina even relevant? So this was the Carmina trial. That was, the hype was that this is the end of the cytoreductive nephrectomy. And you can see that there are two survival curves there, and it doesn't matter which line is which because they're essentially the same. And this is about 450 patients that were randomized over 8 years, so that it actually didn't meet the number of patients it wanted to get to, and it took a long time, but still a very valuable data set. And you can see and so patients were randomized to either systemic therapy only, or systemic therapy, nephrectomy followed by sunitinib. And the idea was to show that the sunitinib alone is not inferior to the combination. And it wasn't inferior, but it actually, if you look at it, it looks like it might even be a little bit better. We can't really say that based on statistical means, but clearly it looks from this trial like you don't need a nephrectomy. The important point, or some of the important points, are that these are relatively high-risk patients. So these are patients with very significant disease, and we define risk by specific criteria. So things like performance status, which is sort of a general measure of how well the patient is doing, and how well they can do their activities of daily living. Also some blood tests. Importantly, there's also a factor in there, the time from first diagnosis to treatment with systemic therapy. And that makes sense if you have a patient who maybe has a nephrectomy and then later on develops metastatic disease. But we're talking about patients who still have their kidney in place in this context. So everybody gets a point for that one. So there are no low-risk patients here. It's all poor and intermediate risk in the context of cytoreductive nephrectomy. Anyway, it was a very high risk population. We would generally never have offered a nephrectomy to high-risk patients or poor-risk patients anyway. We didn't really need this clinical trial to tell us that. The other thing is that we only think of cytoreductive nephrectomy if the vast majority of the cancer is in the kidney, and we're going to be removing that surgically. If more of the cancer is at the metastatic sites, whether bone, lung, liver, wherever else, we generally wouldn't do nephrectomy. In this trial, the numbers in the bottom there are trying to indicate that about half of the disease was outside of the kidney. And usually we would like that to be, a quarter or less. So there are issues with the trial, and the issues are the reason why cytoreductive nephrectomy is actually not a thing of the past. It's something that we will still continue to do. One issue is that if the physician enrolling the patient on the trial or thinking about the trial thought that the patient would be best with surgery, that patient had surgery and didn't go on the trial. So the patients likely to benefit most from surgery didn't go on the trial, which of course is a problem for the outcomes. I mentioned slow accrual didn't meet the overall number expected. Includes a lot of poor risk patients who we wouldn't generally consider anyway, bulk of the disease outside the kidney. And then there are a lot of patients in both arms that didn't get the treatment they were supposed to. So there are patients in the sunitinib only arm who ended up getting surgery. And the suspicion here, or what probably happened, is that patients were doing really well. Their disease shrunk everywhere except they still had a significant kidney tumor, and then they had the kidney removed, which probably contributed to a good outcome as far, we don't know, but we think it might have. On the other hand, the patients who had nephrectomy first, it was almost the same percentage, 17%, who actually never got sunitinib. And of course, that's the worst thing we can do to a patient, is to put them through a big surgery with a lot of potential complications, and then they never get the more important treatment, which is the sunitinib. So how has it impacted treatment of metastatic kidney cancer in BC or in Canada in 2019? One thing, especially for us as urologists who are often seeing these patients first, is that we have to think about the risk stratification, and the patients ultimately should be thinking the same, but we need to risk stratify all patients according to either the, usually now it's the IMDC criteria, so the so-called Heng criteria. In the trials, it was, some of them were the Memorial Sloan Kettering criteria, but there are standard criteria that we go by. As a urologist, I would no longer just say, okay, you're getting surgery, let's go. I would always talk to one of my medical oncology colleagues, and it really has, for sure now more than ever, it has to be a multidisciplinary decision about what should come first. And I think that we are less likely to do a nephrectomy now than we would have, and that what the trial really shows us, that there are patients who are never going to benefit from a nephrectomy, but there are a lot of patients potentially where you want to try systemic therapy, make sure they respond well, use that as a litmus test to make sure the patient's going to respond well, and then do surgery in a delayed fashion. The ones where we would actually do surgery up front are going to be the ones where you might actually consider treatment to one or just a few metastases. So maybe Dr. Chu will pull out his magic radiation guns and shoot a bone lesion, or we'll ask a thoracic surgeon to cut out a lung lesion. There are different things that we can do. So that for sure, those patients will still get surgery. Or if Christian, for example, thinks the burden of disease is not that much that we want to hurry into systemic therapy, and we're going to watch for a while anyway, which we certainly do, then that's a patient who might get surgery first. And of course, it's important that the metastases aren't causing a lot of symptoms. Otherwise, I think our thinking has moved more towards trying systemic therapy first and doing surgery as consolidation later, if the patient does well. So the questions have now evolved. This is my last slide. Is the role of nephrectomy different now that we're back to immunotherapy, immune checkpoint blockade? And especially, is this idea of consolidative nephrectomy the way we should be doing? And there is a trial, I think, that's still in the planning phase in the U.S. Is U.S. trial, Christian, the PROBE trial, I think?
so.
Yeah. So there is a trial planned to look at the timing of this. So cytoreductive nephrectomy is still a thing that we're actively doing. It's part of a multidisciplinary consultation, and we'll see what these trials show moving forward. Thank you.
Any questions? Yep.
What is the degree of freezing you use for cytoreductive ablations?
What was the degree of freezing, did you say?
You use freezing there, right?
No, it's usually surgery. It's usually actual removal of the kidney. So cytoreduction is just, debulking. It's a debulking surgery to get rid of, we don't go in thinking we're going to remove everything, but we want to get rid of as much as we can with the idea that that'll help systemic therapy. So it'll help, we think that the tumor in the kidney can suppress the immune system, and if we get rid of it, we might get a better response to the rest of the disease. We also think that the tumor in the kidney can potentially send off new metastases, and so if we can get rid of that, that might be those are some of the ideas behind why it might be beneficial, but there's no freezing.
If there are no further questions, we're going to move on a little bit to the myth section. And what we would like to do is just discuss a couple of points of question from patients, which we fairly frequently get in our daily practice. And we already had a question this morning about famous Dr. Google. How should we use, what do we think about Dr. Google, and how do we approach that question? Since it is really something extremely frequently in our practice that patients come with all sorts of information from the internet. So I would like to give that question to Dr. Noonan and ask, how do you deal with that question when you get asked in clinical practice and patients come with lots of information from the internet?
Yeah, typically what I usually do is I tell them about Kidney Cancer Canada and review that website with them. And if they don't have access to the internet, I actually am able to print off the handouts. I do put a warning out there that just, these random sites are not, haven't been peer reviewed, most of them. So it's important to get their information from reputable websites. And most of my patients actually do go to Kidney Cancer Canada website, which is really helpful. So yeah, what about you, Joe?
I think similarly, I think it's always good and helpful to ask your physician about sites that they would recommend. And just like when you Google anything, you never know where the source is coming from. So I do recommend talking to your doctor about that.
Do you get that question in your practice, Peter?
Well, usually it's a very specific point, not a general Dr. Google, but patients come in saying, I heard whatever is very good, I need to take high-dose vitamin C for my kidney cancer. And so you just have to spend some time and explain the lack of evidence usually supporting the claim and redirect towards what we know is beneficial and away from things that are completely random and arbitrary.
And I think that is one of the big benefits of the Kidney Cancer Canada website, that every medical information which is posted there is actually peer-reviewed by a medical advisory board, so it is really up to date and avoids any unsubstantiated or wrong information. And this is something, if you as patients go on the internet, it's very difficult to differentiate what the source of the information is. A lot of very, very well reputed cancer centers and societies have information out there that is probably okay. But I think it's always important to discuss that and see whether that's actually the case. Any questions about that from the audience? No. Another very frequent question, since we have a Liberal government whose number one political priority was to liberalize cannabis. Should I take that? Can I take that? Does it improve my cancer outcome? What do you tell patients, Joanna?
So I will agree it's a very frequently asked question. When I'm asked about it, I try to explore the sort of the intention behind that question. So is someone interested in cannabis for treatment of symptoms, or are they asking me about any information about a therapeutic effect behind cannabis? So trying to discern what's, where that question is sort of coming from. I think that there's certainly literature to support using cannabinoids and their related products in the management of symptoms with other standard therapeutic interventions. So I would not recommend that as a sole treatment, but to work with other standard medications that we have for symptoms related to cancer process or other disease process or symptoms or symptomatic situations. I think the tricky bit is trying to get a sense of are cannabinoids therapeutic in any way? Does it help treat a cancer? And I think where we stand now in a time where it's legalized, this is really our opportunity to study that. So I certainly am in a position where I could not recommend it as a therapeutic option because I don't think we're there yet in the literature. It has not been robustly studied yet, but I do support clinical trial opportunities to evaluate that question. I think that's a good question to ask. But I don't think that we're in a position right now that it could be a recommended standard treatment alongside with our own standard recommendations.
Okay. Anil, you have some information on that.
Sure.
Are you surprised?
Well, Hamilton is the
I thought you were the cannabis expert.
exactly. Why do you think I'm so happy today?
I mean,
So we have a Center for Cannabis Research in Hamilton. Of course, being Hamilton, we would have that. So it's actually, we have a couple of world-renowned experts in cannabis research. And we're putting together a what's called a best practice report through the CUA to guide patients and doctors about the benefits of cannabis. We're recommending, in a nutshell, that cannabis be recommended for symptom control, but not for treatment. So we do have a lot of patients. There's some prominent patients in the room as well as that have been there that recommend cannabis as a treatment. Many patients are taking cannabis oil. We're not saying that that's the wrong thing to do, but we're saying that there's no data to support cannabis oil for the treatment of your cancer. It probably is not harmful, but when you ask your doctor about, is this going to help our cancer, we can't answer that. There's no research to say that it does treat your cancer. But for symptom control, there is some benefit, and you should go to a cannabis expert like Christian for your symptom control.
that's correct. I'm from Germany. In case you don't know drug policies in Germany, it's an absolute no to anything. Okay, we have to wrap up the session in a second, but I would like to Peter ask something. I heard that there is a cure for cancer and the physicians and the pharma industry is just hiding it. Is that true?
Well, if
Just because then you can't pay your mortgage, and that's why you don't tell us that.
no, I think the same thing, but it's the medical oncologists who are hiding it from the rest of us. If it's there, I'm in the dark too. But yeah, no, I don't think that's the case. I think there's too much money to be made by the pharmaceutical company that has that secret. But yeah, I mean, I think there, in general, there is some patients, I would say, a small minority, have the suspicion that pharma is somehow working against them, and I don't think that is justified. I think we hear a lot about high prices and profit and all this stuff, but ultimately it's an expensive business, and I think the vast majority of all pharma activity is done for the benefit of patients. So no.
Good. Any other questions before we move on, because we are running late? Okay, thank you very much.